The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and thank you so much for joining us. This is Bethany O'Connor from Health Policy Plus. I am delighted to welcome you to today's webinar entitled Pivoting During COVID-19, How Policy Implementation Enables Health Service Delivery in a Pandemic. We have a great broadcast for you today, and we'll begin with just a few announcements. First, this session is being recorded, and we will post the recording to the HP Plus webinars page, and I will drop that link in the chat box in just a moment. We would love to hear from you, and we welcome your questions at any time. Please submit your questions via the chat box on the right-hand side of your screen, and I will read them aloud when we pause for questions. These web conferencing platforms are getting an unusual amount of traffic, so we ask that you bear with us in case there are any glitches with the technology. And finally, we ask that if you're not speaking, please mute yourself to keep the line nice and quiet while others are talking. And that concludes the announcements portion, and now let's meet our panelists. Next slide, please. So during today's presentation, we're going to first hear from my colleague Mir Rahimzai, Senior Technical Advisor from Palladium. Then we'll hear from Claire Quiner, Research Public Health Analyst from RTI. Then we have Jeffrey Barnes, Project Director, NPI Expand Palladium. And then we'll hear from Mariela Ruiz Rodriguez, Education Development Officer from USAID. So we have a great lineup for you today. And without further ado, I'll hand it over to my colleague Mir. Mir, whenever you're ready.
Thank you so much. A very good morning, good afternoon to the audience. And I would like to thank them for joining us today. It's an honor to be part of this distinguished panel. My slides are going to focus mainly on three specific topics: building critical care capacity, engaging local partners, and coming up with mechanisms to ensure cross-country learning. But before that, making sure that the agenda for today's meeting is introduced here. A quick introduction, which was already done, strengthening case management, infection prevention and control capacity. That's a presentation that I will give. Strengthening lab capacity, my colleague Claire Quiner will give that presentation. Engaging the private sector, Jeff Barnes will speak about the experience with the Expand project, and summary and conclusion that will be after the with the Q&A session facilitated by Bethany. Next slide, please. Thank you. Next slide. Unfortunately, the number of cases, COVID-19 cases, and the number of deaths doubled in last 20 days in the three Central American countries that we are working with, naming Honduras, El Salvador, and Guatemala. This has created a huge challenge for the health systems in these three countries, and we know that this is not unique to these three countries. Many other countries in the world are also facing similar challenges. The number of cases are increasing, and this health system is hospitals and health facilities are struggling to cope with the workload, with the number of patients, with the number of samples, that are coming to them. Next slide, please. We collected data from 9 hospitals in Honduras just to find out how health system is prepared to respond to the surge of COVID-19 cases. Unfortunately, we found that almost half of the hospitals faced shortage of oxygens. Pulse oximeter, which is a simple, easy tool to measure oxygen level in patients' blood, is in fact not available, were not available in 7 out of 9 hospitals in about half of the cases. nurse to patient ratio is more than 1 in 5 in ICU, and 1 in 5 was in fact the highest level in our rapid assessment. So in ideal situation, it should be 1 in 1 or max 1 in 2. Trained professionals who would know how to do mechanical ventilation were available only in less than 50% of the time. Infection among health workers is another major challenge, and it ranges between 5 to 10%. Other basic supplies and equipment like oxygen flow meters, manometers are in a huge shortage. There is a lack of storage for the oxygen cylinders in some of these hospitals, and also most of these hospitals mention that they need a training on how to use personal protective equipment. Next slide, please. So based on a request from the government of Honduras, U.S. government donated 210 ventilators to be distributed to the hospitals responding to COVID-19 pandemic. So we formed the task force in collaboration with the Ministry of Health as well as USAID to make sure that these 210 ventilators are distributed to the hospitals which are in fact in need and are able to put them in use quickly and benefit the COVID-19 patients coming to these hospitals. Through this task force, we engaged about 22 hospitals, conducted a rapid assessment, and identified how many ventilators should go to which hospitals. It's very important to say that the Ministry of Health of Honduras showed a great leadership in engaging partners and being ready to have a detailed conversation at multiple levels up to the Minister of Health to make sure that these equipment are in fact distributed to the right hospitals, and I would like to thank them for this strong leadership. Next slide, please. So the rapid assessment was meant to identify hospitals which would receive the ventilators. We are about to complete a detailed assessment of 22 hospitals which would guide future actions in order to build critical care capacity in 22 hospitals in Honduras. About half of these detailed assessments are done, and the remaining half would be done hopefully soon, which will guide future actions to build capacity and critical care capacity in Honduras. And similarly in El Salvador too, we are doing exactly the same, introducing the same interventions. The tool that you can see was developed by University of California, San Francisco, and we translated it into Spanish, and data is being collected. Next slide, please. So here you can see the distribution of ventilators to 17 of the 18 departments of Honduras. Those in the dark red are specialty hospitals, and the orange color are general hospitals, and the circles are basic hospitals in receipt of the US government donated ventilators. And you can also see the map which shows the number of cases in different departments in Honduras, the number of COVID-19 cases. Next slide, please. So the rapid assessment showed that only 10% of the critical care health workers were trained on how to provide critical care. So we decided to develop a training curriculum and a training plan. The training plan is focused, the training curriculum is focusing on how to provide mechanical ventilation, how to monitor patient in the ICU, and it also includes some quick, easy to understand algorithms which would help frontline health workers move patients from one level to another level. And it also has at least 3 clinical cases which shows different scenarios and make it easy for the trainees to understand what to do and which situation. And this training also includes a section on how to use the US government donated ventilators. Next slide, please. In order to avoid disruption in service delivery, we have integrated training on personal protective equipment and this training on mechanical ventilation. It's a 4-hour training, which includes this training on PPE too. The major focus areas identified were taking on and donning and doffing of PPE equipment, hand washing, respiratory hygiene, as well as identifying and introducing specific processes to make sure that personal protective equipment are available in different stations, as the health services are provided, whether that's a nursing station or a doctor's station or a storage or places where PPE equipment should be available. Next slide, please. So training is good, but not enough. We have also a plan for a structured coaching and mentorship program where a team of 10 to 15 mentees will be connected to a mentor through technology. So using simple tablets and monitors, and frontline health workers would receive need-based support from these mentors during the flexible hours as well as whenever they need them. Next slide. In order to make this mentorship and capacity building program more sustainable, we have engaged local professional associations, Association of Intensive Care Specialists and Association of Anesthesiologists, or probably, as well as nursing associations, are in the forefront of critical care in most of these countries. And it's very important to mention that intensive care specialists are very few in each of these countries, maybe ranging from 50 to 100. And it's extremely important, and they're mainly based in major cities. So it's extremely important to engage them in a way so that they can share their expertise with hospitals which are in rural areas and which are away from major cities. We have also access to a US-based intensive care specialist who will provide need-based support to the local associations as well as to the trainees on the ground. Next slide, please. And this is my last slide. In order to make sure that these three countries, in fact, talk to each other, share lessons learned, and also plan together, we have put together a monthly learning session where our staff, at least at the beginning, and hopefully in the next step, we would be able to engage hospital staff from these countries to talk to each other and to exchange their experience, to learn what worked, what didn't work. And we hope that this will improve speed of implementation as well as improve efficiency as we are responding we are helping these countries to respond to the COVID-19 pandemic. With that, I would like to thank you and would like to pass on the presentation to my colleague, Claire Quiner, who will speak to you about the lab capacity development in these countries. Claire, please.
Thank you, Mir. As Mir mentioned, I am leading the laboratory pillar of this project, so I'll switch gears here. The cornerstone of laboratory for SARS-CoV-2 is the PCR test, so I'd like to take just a moment to describe the basic steps of that process. Next slide, please. We begin with our sample, typically a nasopharyngeal swab collected from a patient. Once that's brought into the laboratory, the first step is to extract the viral RNA, at which point, once you have the raw nucleic acid, you mix it with PCR test kit chemistry, and then that gets loaded onto a PCR amplification platform, which goes on to give you a test result, which can be interpreted as positive or negative for SARS-CoV-2. Next slide, please. In supporting Honduras, we wanted to take a look at a couple of different strategies that may be best for the country with regards to how to approach the testing. Testing strategy one, which is kind of the very basic or standard approach, is a manual RNA extraction. Here you can see a technician pipetting, followed by PCR test kit chemistry, and then PCR amplification on an open platform. Next slide. Testing strategy two replaces the manual RNA extraction with an automated one. Here we have a Pioneer automated extraction procedure, and then the downstream steps are the same as in testing strategy one. Next slide. Testing strategy three, all of these steps take place in a single platform. Here we have an Abbott platform. You load your sample onto the machine and it does all of the work for you. There's no transferring of the sample, etc., etc. And this strategy was the one that was the point of focus at the time that we began our work with Honduras. We wanted to do an analysis that would provide information so that they could make the best decision. Next slide, please. So how do you do an analysis with very little information and remotely? We began by asking our in-country coordinator, Dr. Soto, to do a lab-level inventory of key laboratory commodities. Here I've listed two of them. So listed here are the 4 laboratories in Honduras who are performing SARS-CoV-2 testing. There were a total of 5 open PCR platforms in the country. Those are the ones used in testing strategy 1 and 2, and Abbott M2000, the one used in testing strategy 3, there are currently 2. In terms of the Pioneer, the automated RNA extraction platforms, there's essentially 396 well in country. Next slide. The first question that we asked were, what were the time requirements for each of the 3 strategies that we outlined? For testing strategy 3 with the manual RNA extraction, it takes 5.8 hours start to finish. Testing strategy 2 is reduced significantly to 3.62 hours, and that's because the automated takes so much less time. In testing strategy 3, it takes about 7 hours start to finish. So we took these data and we said how many samples could be processed within a 24-hour time period. Next slide, please, using each of the 3 strategies. So here I list the data in 2 different ways. And just a note, all of the laboratories are working 24 hours a day, 7 days a week in order to process as many SARS-CoV-2 samples as possible. So here we have the number of samples that could theoretically be processed using each of the strategies per platform. And then we also show the daily maximum capacity using the existing platforms that are available in country. Again, 5 open PCR platforms and 2 of the Abbotts. So here we see using testing strategy 1, they theoretically could process about 2,100 samples a day. Testing strategy 2 gains us an additional 1,000 samples every day, getting us to 3,100. In testing strategy 3, where you can only process about 320 samples per platform per 24 hours, they're only able to process about 645 samples per day. Next slide. We wanted to go on and compare additional parameters across these 3 strategies. We also looked at time and labor requirements, consumables, and the maximum daily sample processing capacity, which I just showed you. Next slide. Looking at time and labor comparison, in testing strategy 1, that initial manual RNA extraction process is lengthy and time intensive, and there's no walk away time, so the technician is there pipetting throughout the entirety of that time. For testing strategy 2, the process is shortened to about 50 minutes, and it's less labor intensive as the technician can go on to do other things while the machine is doing its work. For testing strategy 3 and Abbott, it's time and labor intensive initially to load the samples onto the machine, but start to finish, it's a long walk away time, about 6 hours, at which point that technician is free to do other things in the laboratory. Next slide. Lastly, we wanted to compare consumables across the 3 strategies. It's important to understand that for testing strategy 1 and 2, you do have to buy a specific RNA extraction kit. For testing strategy 1, it has to be Pioneer. For 2, it has to be Pioneer. For 1, there are several that will work. But once you have that RNA, you can go on to do whatever. You're not tied to a particular machine. You can do whatever you want with that RNA. Additionally, for testing strategies 1 and 2, upstream, there's no specific tubes or consumables that are required. In other words, these 2 systems are very compatible with anything else that's going on in the laboratory. Testing strategy 3 is different. At the time of sample collection, this process is most efficient if you use the Abbott proprietary sample collection tube, and downstream you need Abbott-specific consumables, chemistry. Everything has to be specific to Abbott, which makes it very difficult to integrate with the other things that are going on in the laboratory. So we were able to provide this analysis to Honduras and let them make a decision about what the most efficient testing strategy would be for them. And in fact, they decided to invest heavily in testing strategy 2, the automated RNA extraction platform. Now that we also had this information about the maximum daily processing capacity, we wanted to further use this analysis. So we asked the question, how is Honduras able to meet or not meet their daily maximum testing capacity given equipment that's currently in the country? Next slide, please. Based on what I described, we knew that they'd be able to process between 2,500 and 3,000 samples a day based on what they have in country. And that's what the red line here represents. The first thing that I want to highlight on this slide here, in gold, we're showing the number of samples that are processed every single day in Honduras since about mid-May. And the number of samples that they've processed has increased by about threefold. And that is a testament to very strong leadership in the laboratory, as well as very dedicated laboratory staff. So we just want to recognize that. Using this graph, we can see that there's quite a bit of variance day to day in what they're able to process, and it's unusual that they're able to meet the maximum testing capacity. So we're able to use this graph to go on to have a very fruitful conversation with laboratory staff about what some of the challenges were to meeting this maximum testing capacity every day. Next slide, please. Here, the biggest challenge that they identified to productivity was a lack of a sample and data management system, that upon receipt of samples into a laboratory, there was no formal accession process, there was no digitized system to keep track of where samples were in freezers and refrigerators, what had been tested, what needed to be tested, et cetera, et cetera. Additionally, there were insufficient laboratory supplies, and they identified a disconnect between solicitations made to partners and fulfillments. Finally, there's ongoing issues with equipment and supplies that involve delays in customs. Equipment is broken upon receipt, and oftentimes incorrect equipment is ordered. Here in this picture, I'm showing what is supposed to be a biosafety hood with proper filtration to protect the laboratory workers from the respiratory virus that they're handling. But instead what they got was a safety hood that's intended for toxicology, and that's what those big gloves are. Those gloves are not going to fare very well when you're using the very tiny little test tubes that are required for this type of work. So now they have to figure out what to do with this large piece of equipment that doesn't really serve any of their needs. Next slide, please. Just to take a moment to talk about some of the accomplishments that we've been able to do to date. We performed that quick analysis of commodities, human resources, and identified those main challenges. And we were able to quantify the most efficient testing strategy, which again is going on to inform the procurement strategy and decision-making for Honduras. This will serve for long-term planning, as testing strategy 1 is compatible not only with SARS-CoV-2, but whatever the next global pandemic virus is. It'll be easier to adapt than the Abbott. We've also established a significant working relationship with the laboratory coordinator and laboratory staff. This has been key to productivity. And finally, we've been able to hire some key personnel to address some of their needs. I mentioned before our in-country coordinator, Dr. Soto, who's been key to our success, as well as an IT specialist who's on the ground as of 48 hours ago, who's working on a sample and data management plan, as well as 2 laboratory personnel who we've brought in to support day-to-day operations, do some pilot testing to understand some different testing strategies that they may want to employ, as well as implementing verification protocols and things of that nature. And finally, we're working on a data use agreement. We've been asked by the ministry to support in data deduplication and cleaning, and we'll also be performing some epidemiologic analyses that will support an ongoing decision-making about where to direct resources and understanding exactly what SARS-CoV-2 is doing in Honduras. Next slide, please. I just want to wrap up with a few key takeaways. The first is that every bit of information and data counts. Beg for it, scrape it, pull it from open sources, whatever you have to do, get any information and figure out how to use it. This is significantly different than I think what our public health training prepared us for, which was that you design a study, you get some nice clean data, and you analyze it. This is not that. You need to be creative with what you have and figure out how to use it. Next is to go granular, but to extrapolate. Laboratory personnel are very good at being focused and localized at exactly what's in front of them, and that's it. This is what makes them good at their job. Funders and regulatory agencies are very good at thinking globally and trying to look at the big picture. This is what's good at their job. There is an inherent disconnect between those two pieces, and I've seen the work of HP Plus as the conduit between those two, speaking a common language where there isn't one that naturally exists between them. I also want to highlight that the easiest and fastest approach may not be the most efficient. Do the research, do the math, get the information to people so that they can make the best decisions for themselves. I also just want to recognize again the importance of establishing a direct line of communication with a point of contact. People who are actually doing the work will reveal things to you about challenges in their situation that may not be quite as apparent to their superiors. I also just want to highlight that we need to be ahead of the curve. We all appreciate the urgency of the situation and that things are changing on a daily basis. Our regulatory agencies are not designed to be agile in this way, and so it's important to be identifying solutions, and if there isn't formal approval, also designing studies to make sure that it does work for that situation, but really not be independent or tied to these large governing bodies that are struggling to keep up with what's required of them right now. And I just want to end on one note that it's important to identify the needs and not to let one's own limitations get in the way of understanding them. It's been a pleasure to work with a very talented team and a very talented group of people who have supported in many ways a lot of this technical work despite their lack of laboratory background, and that has been a very fruitful part of this project. That's all I have to say today. I can pass the microphone on to Jeff.
Okay, thanks, Claire. So I'm going to bring in a slightly different perspective about working with the non-state or the private sector. Next slide. Although something like a global pandemic requires almost always a state-led response, the state is not always the sole actor, and the state can play a role of stewardship. And so one of the key policy decisions that most countries are making is to involve the non-state partners in a wide variety of ways. And I think there's increasingly global recognition that the health system includes all different parts of all sectors, and an effective response requires all sectors to respond. Most obviously, in almost all countries, there's a mixed health system. There are private sector service providers that run hospitals, clinics, and many consumers prefer these providers for their primary health care needs and emergency needs. So it's critical that these providers not be forgotten. When there are new protocols and new guidance coming out on a brand new disease, of course, it's critical that these providers be trained in protocols, that they are built into the system in terms of identifying cases, conducting testing, and getting the latest information about treatment. Another part that's critical is, as we've seen, even when the treatment is at state of the art, community participation is critical. Behavior change is a big part of managing this pandemic, and one of the best ways to do that is to mobilize community groups and associations. They, first of all, need the information, and they need to be mobilized with accurate information about what the risks are, how to mitigate the risks, and how to organize as a community. So this is also a critical strategy. Finally, there's the commercial sector that is a big part of society and plays a couple of key roles. First of all, in all developed countries, a big part of managing risk has to do with setting appropriate workplace policies in place and trying to avoid, crippling the economy by having social distancing practices and mitigating risk in the workplace. and commercial sector in other places has also invested in the response. Next slide. So I want to talk about some of these examples from the NPI Expand project. We're also a global project, and again, with the COVID, we've also been asked to pivot towards handling some of the COVID mitigation priorities. In Mali, as part of the community response, the importance of religious leaders was identified as a priority, and so we're using that as kind of a key channel for engaging communities, informing them about risk mitigation. Religious leaders are obviously a very trusted source of information, so we're mobilizing them proactively and using them to help manage rumors and myths and advise people accurately on how to do that, and to ensure social distancing in religious places of worship. In Liberia, there are a couple of things. We have a partner for the Healthcare Federation of Liberia, of Association of Private Service Providers. They were engaged early by the government, so they are fully on board with what the government's response is and what the treatment protocols are. We've also been issuing grants to community groups to do engagement, management of rumors, identification of possible cases, and referrals. In this case, Liberia had proven NGOs that had gained some critical experience in this during the Ebola epidemic, so some of those lessons learned were applied for responding to COVID. In Tanzania, we're also mobilizing 3 local community associations that are doing both risk communications and social marketing of non-medical masks. And so that giving people a very concrete behavior that they can adopt in addition to learning how they can mitigate the risk. In Brazil, we're supporting the USAID Brazil and a public-private partnership association that they have established, where there's a fund where corporate sponsors support local NGOs in the Amazon area, and they're doing a variety of activities from distribution of personal protection equipment, hospital equipment, behavior change communications, and loan programs and food distribution to mitigate economic impacts. In Senegal, we're also mobilizing community groups, but there it's primarily for surveillance in the 3 districts that are most affected by COVID. They're going to be conducting household-level visits to identify possible suspects, refer people to the appropriate health posts, and to collect data and share that with the health posts in those districts. So that's all I have to add in terms of the private sector perspective. I'd like to turn it over now to the last speaker, Mariela Ruiz Rodriguez, the Education Development Officer at USAID Honduras. Thank you.
Thank you, Jeff. Good morning, everyone. So I was asked to, and I am the Office Director for the Office of Education and Workforce Development at USAID Honduras, as well as the new coordinator for Global Health and PEPFAR funds for COVID response. And for today, I was asked to respond to the question, what is the role of implementing partners in developing and implementing policy to strengthen COVID response? So I'm speaking specifically to the role of implementing partners for USAID. And I would say that implementing partners bring in the needed expertise and the global experience necessary for implementing policy changes to strengthen the health systems and make them more resilient for COVID, but also for any other type of emergency response. In Honduras, specifically, the role of HP Plus has been multidimensional. And I think their role highlights necessary aspects of implementation that any IP, any implementing partner should keep in mind. So while implementing partners bring global experience and global standards, their specific expertise allows them to be flexible. And I think flexibility is key in any response. they are able to adapt the knowledge that they bring, the standards that they understand so well, to the context of the country. Because not every country is at the same place in terms of responding to emergencies. In some cases, it is basic knowledge transfer. In other cases, it is creating the platforms for information exchange. And in other places is complementary support. I think another aspect, important aspect and necessary aspect of implementation is that our implementing partners are able to focus on systems optimization in the short run, in this case for immediate COVID response, but also be intentional about strengthening the systems as a whole, to be able to respond to basic needs in a quality manner, as well as to needs during future emergencies. We cannot just think about the now and the right now. We must respond for sure and have immediate responses, but our work plans and our thinking has to be longer term. We have to think about how the system is responding. In this same line of thinking, we need to ensure that the adaptive capacity of the system is strengthened for the long term, so that the response doesn't create dependencies. Ensuring that our response is quick and timely for COVID cannot take away from a system, cannot make him dependent on our aid. And we cannot take the place of or the responsibility for the role that governments and other key actors have for health systems. I think a final point I want to bring to the table today is that the role of the implementing partner is to build partnerships. Partnerships with governments, partnerships with private sector, and partnerships with local actors. And this is really, really important because, you know, people describe our implementing partners as they are our saviors. They are our angels. Without them, we cannot survive. And my response to that would be, boy, what did we do wrong? How do we fix this? And luckily, I think HP Plus has been very consistent in building those partnerships. Not coming in as the rescuer or the savior, but coming in as a partner, ready to support information gathering, ready to present options, and to create those spaces for information exchange, for analysis of data, so that key actors and players who have their responsibility for actions in the country can make better decisions. And I think that's a really important point to keep in mind, that partnerships means that we all come to the table with something to contribute, and that there are key actors in the countries that have a role. They may not fully see their role within the big picture, but it is part of our job to model good transparency in decision making and broad engagement of key actors and players. Thank you for the opportunity to share these thoughts with you, and I give the microphone back to Bethany.
Thank you, Mariela, and thank you, panelists, for your fabulous presentations. And now is the time where we want to hear from you, from our audience. We're curious to know what you want to know more about. So this is a great time to type any of your questions into the chat or questions box. And while those roll in, I'll start reading off the first two we've received. So the first one is, what helped the implementation of activities? And then can you speak more to what challenges did you face? And I'll turn it over to any of you panelists who want to weigh in first.
Sure, Bethany, thank you so much. So this is me. Maybe I will start and my colleagues can add. In terms of what helped implementation, I would say a number of things, helped the implementation. A very strong local USAID leadership, and I would like to thank Mariela for providing the leadership in Honduras, and we are seeing, similar engagement in El Salvador, as well as in Guatemala with our country team. I think that helped a lot in providing the vision and direction. On the government side, I believe the openness and the flexibility and the engagement that we experienced in Honduras, right from the Minister of Health to, Director of Hospitals, Dr. Lizardo, in each hospital director, I would say that's commendable. And that, in fact, helped a lot in moving things faster and also, making sure that activities are implemented on time. So I think that's the second factor. The third, I would like to also mention that the local team on the ground, the consultants and advisors who have been hired to do the work, were also very proactive. They were thinking about what to do, planning for tomorrow, in addition to doing their work today. Despite of the fact that there were numerous challenges that each and every one of us have been experiencing since last 4 or 5 months. For instance, with the number of cases increasing, cities have gone into a total lockdown. Moving from one part to another part was not only physically difficult, but also it was, there was security risk involved in empty roads going from one place to another place. That was a challenge and a problem, but our staff were still able to do the work, as it should be done. To the second part of your question, I briefly answered the one aspect of the challenge, which was related to the lockdown and the number of cases. There were challenges at multiple levels, and maybe if I may just give a few examples. We have identified 7 trainers to do the critical care capacity training. 2 of those 7 trainers were unfortunately tested positive, and they had to go into isolation. A task force member, a senior intensive care specialist at the beginning, was tested positive and had to go into isolation. The frontline health workers, nurses, doctors, and lab technicians were among those who were mainly affected by COVID-19 infection, and they would go for 10 to 14 days isolation. So that was another challenge, that on one side you train and build capacity, on the other side you lose so many people to infection. So that's another level of challenge that were in front of us. But the good thing was that the staff on the ground were, aware of these challenges and were always thinking about plan B. They were always very flexible. As Mariela said, flexibility was a key, and how to do trainings. I remember at the beginning, it was said that no one will come to these trainings. People are thinking about survival. They don't think about, coming to training and capacity building at this time. However, that was proved wrong, simply because, by now more than 120 frontline health workers out of 400 target have been already trained, and they came to the training room, they participated in the training, and they went through a 4-hour session. Yes, maybe in with all the personal protective equipment and necessary infection prevention measures in place, we were able to conduct these trainings and bring these people to the same place. So just that, those were some quick examples of some of the challenges that we faced and some of the factors that helped implementation. And I will let my other colleagues to share their thoughts.
I'll just add.
Go ahead, Jeff.
Yeah, just quickly, I mean, one of the unique things about this pandemic is complete inability to travel and to work face to face. And for NPI Expand, we had no country offices in the countries. So we became very reliant on the USAID missions to help us identify viable local partners, and I have to say that worked very well. The USAID missions were wonderful in collaborating with us and really helping us kind of co-design and co-launch the programs. But doing this kind of work without being able to work face-to-face or being able to travel or have staff is definitely a big challenge.
I would just add, something we don't often mention, but we do need to be aware of, is that politics and corruption can be challenging in some countries. They can be a real challenge to make policy changes. But I think it's really important for us to remember that it's not our role to engage in politics, but to strengthen the systems. And that all our efforts have to be technically based. They have to be clear, transparent, evidence-based technical recommendations and actions. And to not join the chaos that sometimes politics can bring in times of disaster and emergency. Sometimes it brings us together, and sometimes it doesn't. But I think our role is clear. Model how the system can be more efficient and effective through more transparent and evidence-based decision-making. And I think keeping that in mind is really important at all times.
And just to build on Mariela's comments, I'll say a part of our work that's made everything more significant has been having local partners who are familiar with the existing landscape and know how to navigate and avoid certain politics that Mariela's mentioning, and also just the correct people to talk to and the right questions to ask, and having that local knowledge from experienced personnel on the ground has, I think, made all of our work more significant and impactful.
Great, thank you, panelists. I really appreciate all the perspectives that you all have been sharing with us today. And I'd like to guide us now to our next two questions. So first, what are the plans to sustain the learning sessions between countries? And what are next steps? So panel, over to you.
Sure, maybe I will, again, this is Mir, I will begin. So in terms of sustaining the learning session between these three countries, so that initially what we did was to have the learning session between our teams, simply because hospitals at this point of time are overwhelmed. We have data which shows that some of the hospitals are up to 110%, the bed occupancy rate is 110%. Ideally, it should be less than 80% so that there is a 20% flexibility for any surge of patients. But we know that the frontline health workers are busier than what they were before. So we began these learning sessions mainly with our staff working in these three countries so that they are able to share lessons learned, guidelines that they are working on, so that the other team does not have to begin from scratch when they are working on a specific topic. And I remember that as soon as our last learning session finished, within 1 hour, our team in Guatemala shared their guideline and still draft on how to protect health workers, which is a major priority in El Salvador and Honduras too. They shared those documents with each other. And they are also having phone calls and meetings to learn from the experience of Honduras on how they distributed ventilators, what was the selection criteria. So they have been talking to each other even without having a learning session, after the learning session, without even waiting for the next learning session. So if I may look at it from two viewpoints. One, what they share will last for a long time. For instance, this draft guideline on how to protect health workers, will help the two other countries base their ideas to develop their guidelines on what the team in Guatemala shared. So that will be a policy there that will remain there, and that will be used and updated and revised by the Ministry of Health. But in terms of the learning sessions themselves, these teams are our teams. We hope to go to the next step. So the next step would be to engage the frontline health workers, the teams of frontline health workers in different countries, with each other, so that they are able to continuously use technology, WhatsApp, social media, or other structured, mechanisms in order to share lessons learned with each other. And last point, we also hope that we would be able to document the lessons learned, in these countries, and then make it available to the frontline health workers, hospital directors, in these three countries, so that they can, use that experience for their benefit.
To build on that, I'd like to give several specific laboratory examples about what we're doing to make sure that they're continue to have capacity beyond the scope of our particular project. One thing that was taken under consideration with the testing strategy that I mentioned was that in testing strategies 1 and 2 with the open platform, you're not necessarily tied to a single company. For pathogen X, which may be coming up next, they would be dependent on a single company to develop a test that accurately detects the virus or whatever kind of pathogen it is. Whereas for testing strategies 1 and 2 that I described, there's a number of different approaches that could be used. So it would be more flexible to pivot for anything else that's coming down the line. The other thing that we've seen is that countries like Honduras are in a position where they're really privy to the aid that they receive, and there isn't necessarily standardization across that aid. So what we've seen is that they've received, with regards to test kits, lots of different brands and types, and there hasn't been a standardized approach to make sure that they're all functioning the same, or that they're all created equally. The ones that they received didn't have the FDA approvals or the WHO approvals, which is the standard in many parts of the world. So one thing that our contractors are doing now that they're in country is supporting and establishing a verification protocol to ensure that there's consistency across testing machines and different approaches to the test and the different test kits that are being used. And that'll be something that local staff will be trained on. So going forward, as they receive different things or different things happen in the world, they'll have the tools to be able to test and assess for themselves which test kits work and don't work. This extends beyond just the test kit brands or the particular design of a given company, but it actually can be applied to assess cold chain delivery. This is another issue that's been identified, that the test kits are very temperature sensitive, and the delivery company didn't necessarily maintain cold chain during its delivery to the laboratory. So they'll also have a verification protocol that can be standardized and used upon receipt of every new batch. And if a test kit doesn't perform as it's supposed to, then that data can be taken back to the company and used to justify repayment for that damaged good. That's all I have.
Excellent. Thank you, Claire and Mir. Does any other panelists want to weigh in on the questions around sustaining the learning sessions between countries or next steps?
Maybe just interpreting your question a little bit broadly in terms of our experience and what's going to be sustainable out of this effort. I think for me, there's always institutional learning, and when I look at the way Liberia and Senegal who have responded to COVID, both of those countries learned quite a lot from how they responded to Ebola. And so in both cases, they kind of had a blueprint that they followed for responding to an epidemic that has helped them, keep the epidemic somewhat under control. I think in the cases of the countries we're working with, and hopefully in many other parts of the world, going through this will create blueprints that will help sustain the response and help us learn how to manage future epidemics, future outbreaks of COVID or other diseases.
Thank you, Jeff. Does any other panelists want to share any thoughts, or should we move forward?
Can I just add one in terms of next steps, Bethany? This is Mir. We have been focusing a lot on hospital care, which is important, which should be. We have to be focusing on improving critical care, but we know that more than 80% of patients are either asymptomatic or have mild symptoms who could be taken care of at home, and if properly taken care of at home, we will significantly reduce the spread of infection. So for us, the next step is to move to make sure that we improve case management at home, infection prevention at home, maybe focusing mainly on the households which are most vulnerable, those who have people above 65 years of age, those who have comorbidities. Hopefully we would be able to find data which would tell us that in a community, 10 or 15 or 20% of households are those vulnerable households, and how can we mobilize primary health care, engage community health workers to work with those households in order to improve care at the both case management as well as infection prevention at home. And same like our experience from MNCH and with ANCs and with PNCs, postnatal care, how can we make sure that people at the community level know the danger signs and are able to contact the right person, the right health facility at the right time in order to receive more advanced care. So for us, the next step is to focus on home care in addition to engagement and expanding the critical care capacity building at the hospital level.
Thank you so much, Mir. I appreciate the point that you're making in terms of next steps being focusing on home care and the capacity building side. And that's a perfect note to end on today. So we have covered several angles today. We've gone through enabling local leadership and developing policies and its implementation. We've spoken about strengthening laboratory capacity, the role of local partners and civil society in the response, and finally promoting local engagement and ensuring a coordinated response. We have really, really appreciated all the panelists and attendees for your wonderful questions. And we also just want to acknowledge those organizations without whom this work would not be possible, including the Ministry of Health of Honduras, Ministry of Health of El Salvador, USAID's EPIC project, USAID's Health Policy Plus project, the USAID mission in Honduras and El Salvador, RTI International, and Plan International. We sincerely thank all of you. And we just wanted to let you know that this webinar is part of a broader HP Plus webinar series. And we always post our recordings on the HP Plus webinars page. And that link is in the chat box for you now. And it will also be included in the follow-up email you'll receive in the next week or so. I'm trying to think if there was any other announcement. We do acknowledge that there was some kind of glitch. Not everybody was able to access the link for today. we apologize. We just had a little bit of trouble with the platform. So if you had any colleagues who wanted to attend today and weren't able to, please do assure them that the link is coming out to view the recording very, very shortly. So again, we just want to thank all the panelists, all attendees for your kind attention. And we look forward to seeing you again here very soon.
Thank you so
everyone.
much. Thank you.
Thank you.